right after this one for everybody to get up and walk around and move around and talk a little bit. Okay, so I'm going to keep going on client rights. I'm a little warm up here.
Oh dear.
Okay.
Is it the lights, maybe?
I don't know. No,
Okay.
it's just, talking to work.
Okay.
Having the attention. That makes me happy.
Okay, so these are sort of two separate areas that we need, again, training every 2 years in, and specific training since our audit on client rights and ethical boundaries and helping relationships. So one thing that all of our residential facilities are guided by is the Healthcare Bill of Rights, and this is given to our clients upon admit. This applies to anyone who is admitted to a healthcare facility for longer than 24 hours. So this applies to people in hospitals, in residential facilities, any kind of inpatient unit, those kinds of programs. This does not specifically apply to our outpatient clients or supportive housing, those kinds of individuals. These are Healthcare Bill of Rights for clients in a healthcare facility. So I'm going to breeze through these. Our clients get a copy of this every time when they admit, and we have to kind of go through them again as staff every couple years to remind ourselves of this. And we have lots of copies around the treatment center, so if you ever want to sort of look more into this is not the actual language from the Healthcare Bill of Rights, but I have it here if anybody would like to read them. So I've summarized them here. Clients in our residential facilities have the right to be informed of their rights upon admission. That's why we give them a copy of them. I don't know what they do with them. Do they keep them the whole time they're there and like refer back to them? I don't know, but they could. They have the right to receive courteous and respectful treatment. They have the right to receive the appropriate medical and personal care based on their individual needs, meaning not everybody gets the same thing when they come through our doors. It's individualized treatment. They have the right to know who's responsible for their care while they're in treatment. That is why there's a posting in our public spaces at all of our facilities with the manager or director on site, because they have the right to know who's sort of in charge of their treatment in that facility. They have the right to know what services might be provided to them by people outside of Wayside, by consultants or people like that. So kind of what other services may they be provided while they're at Wayside. They have the right to complete information about their diagnoses, treatment alternatives, risks, and prognosis. So if they ever, it's going to come up again, but they have the right to anything that's in their chart or documentation. They have the right to participate in their treatment planning and to include family members in their care. So we can't ever prevent a client from participating in treatment planning, or we can't prevent them from including family members in their care. In fact, we want to encourage that. They have the right to be cared for with regularity and continuity of staff assignments. So that's an important piece of kind of keeping the same providers as much as possible, or being respectful when we need to make a change in that, and that they sort of know who to go to with for their care. They have the right to refuse care and to be informed of the risks of refusing care. They have the right to leave when they want to. We're not holding them against their will. They have the right to give informed consent to any research or to refuse participation at any time. They have the right to be free from maltreatment and restraint. They have the right to respectfulness and privacy in their care. They have the right to be assured that their personal and medical records will be kept confidential and to authorize release to anyone outside the agency. They have the right to be informed of the rates or payment that we receive for their treatment. And there are, in all the counseling offices, there should be, please let me know if there's not, a posting that has our rates that were paid, as well as their counselor name and credentials, and the Client Bill of Rights, which is a separate document that we'll talk about next. So that's posted publicly in our facilities, and if they ever asked for one, we would need to be able to provide something to them. They have a right to a prompt and reasonable response to their questions and requests. They have the right to consideration of their privacy, individuality, and cultural identity, and as part of that, it's specifically noted in the Healthcare Bill of Rights that staff must knock on their doors and seek consent before opening, except in emergencies. So we have to do that step of respecting their privacy by knocking and announcing that we're staff. They have the right to voice grievances and to recommend changes in policies and services. We can never deny them the right to provide us suggestions or make requests. They have the right to communicate privately with persons of their choice, except when in violation of our Program Abuse Prevention Plan, which is our mandated reporting and our abuse prevention, sort of all the measures that we have in our operating procedures. So this means that they have the right to communicate with anyone they choose, unless we have determined that that's a person that's unhealthy, unsafe, potentially abusive to them or to Wayside. So that's another reason that we can put some limitations on visitors and things like that, because if we believe that that person is dangerous to our facility or our community, that's what that violation of our Program Abuse Prevention Plan piece Okay, they have the right to retain and use their personal clothing and possessions or to have them stored, so we can't sort of take everything that they own when they come into treatment. We have to provide them a way to keep that and to use that if they choose to. They have the right not to provide labor or services for the agency. We give them jobs that they can do, but we would never be able to make that a requirement of their treatment that they complete jobs for Wayside. They have the right to purchase or rent goods from a supplier of their choice, so if there was somebody who really, needed something from a specific provider, we wouldn't be able to prevent that from happening other than sort of reasonable accommodations that we can make and can make. They have the right to manage their own affairs. They have the right to meet with and receive visitors and to participate in cultural and community groups. They have the right to organize, maintain, and participate in resident advisory or family councils. And if they wanted to have a resident advisory council, we would have to provide them a space and privacy for those councils to meet, and if requested, and we must respond to any recommendations that they would have. I don't know if we've ever had a resident advisory council, have we? Anybody who's been here longer than me? Well, someday may start one. They have the right specifically to have visits with spouses, again, unless it's in violation of that program abuse prevention plan. They have the right not to be arbitrarily transferred or discharged from treatment, so that's why we have specific guidelines in our operating procedures about what can lead to discharge, and we want to do as much discharge planning as possible so that we're not just arbitrarily or suddenly discharging them from treatment. They have the right to access rights protection and advocacy services at any reasonable time. They have the right to be free from isolation and physical restraint, and they have the right to a written treatment plan. Any questions about that? Okay. So those are the healthcare bill of rights for residents of a facility. These are the client bill of rights that apply to all consumers of alcohol and drug counseling services. So this is all of our Rule 31 clients at any of our facilities, inpatient, outpatient, anyone who's receiving drug and alcohol services from us. They have the right to expect that the provider meets the minimum qualifications of training and experience required by state law. On that sheet that has our rates and things like that, it also has counselor credentials and license numbers so that they can know that information. They have the right to examine public records maintained by the Board of Behavioral Health and Therapy that contain credentials of the provider. So if they wanted to look their counselor up and make sure that they had a license, they could do that. They have the right to report complaints to the Board of Behavioral Health and Therapy. They have the right to be informed of the cost of professional services before receiving the services. They have the right to privacy. They have the right to be free from being the object of unlawful discrimination while receiving counseling services. They have the right to access their records. They have the right to be free from exploitation for the benefit or advantage of the provider. They have the right to terminate services at any time except as otherwise provided by court or law or court order. They have the right to know the intended recipients of any assessment results, or so if we did some testing or Rule 25 or those kinds of assessments, they need to know who we would be sending that information to. And they have the right to withdraw consent to release assessment results unless that right is prohibited by law or court order or is waived. They have the right to a non-technical description of assessment procedures. They have the right to be explained what they're being assessed for and what that means, and to be explained that in language that they can understand. And they have the right to non-technical explanation and interpretation of results, any testing results, unless that right is, again, prohibited by law. That's it. Those are the client bill of rights. So again, those are posted in our counselor offices. Please let me know if a counseling office you see doesn't have those client bill of rights and our rates and the counselor information. Any questions about those documents? Healthcare bill of rights, client bill of rights? No? All right, let me catch up in my notes for just a second. We're gonna transition now to boundaries. And then we're just gonna take a break. It's still part of this PowerPoint, so it's not break time yet. So the reason this all flows together, and I think kind of all of the things we're talking about today, mandated reporting, client rights, boundaries, emergency procedures, they all sort of tie together because I think when we're talking about ethical boundaries, what we're really talking about is protecting those client rights and reducing the potential for harm or exploitation. And moreover, our ethical boundaries are that we're ensuring that we're providing services that are appropriate to the client, fair, and client-centered to the best of our ability. So that's what, when we talk about ethics or ethical boundaries, that's really what we're talking about, is how are we providing the most ethical care in those different areas. So we have these responsibilities to our clients, just ethical responsibilities. We have the responsibility to be aware of cultural competence and appreciate diversity. We have the right, or the responsibility to be able to identify and manage potential conflicts of interest. And we're going to talk about more about each of these things, the language in these. We have the right to assure that clients have a right to self-determination. We want to guard against dual relationships. We want to protect clients' privacy and confidentiality, and we want to, it's a responsibility of ours to maintain boundaries with clients. We'll talk about what that means. So professional boundaries, I really liked these quotes. It's from the nursing board. Nurses have good, good writing skills about boundaries. Professional boundaries are defined as the space between the professional's power and the client's vulnerability. The power of the professional comes from the position we hold and the access to private knowledge about that client. So thinking about that we have to maintain a boundary because we're in a privileged position of knowing really private information about our clients and earning their trust as well as being able to hold that information. So in terms of boundaries, awareness is the key. Professionals who are clear about their own needs and the needs of their clients and who can separate from the personal from the professional will find themselves acting in the best interest of our clients. So that's really what we want to be able to do, is recognize what's ours, what's theirs, and be able to focus on their needs in the treatment setting. I did some fancy transition stuff that I don't know how to do. Okay, so boundaries mean making a distinction between a personal relationship and a professional relationship. Meaning that there's a difference. So our relationship with our clients is a professional relationship, and that's different than our relationship with our coworkers, than our relationship with our friends. Those are personal relationships. And the difference is really in the power differential, that our personal relationships don't necessarily have a power differential, but our relationships with clients do. We have some inherent power as professionals in that relationship, and we want to respect that, because if we don't, there's possible exploitation. That's what exploitation is use of power to maltreat someone or abuse them. So it's maintaining a line between the self of the client and the self of the worker, and knowing what stuff and responses are ours and what things that we need to be able to let our clients do and decide for themselves. And moreover, this is an ethical framework in which our worker-client relationship occurs. So the point of boundaries is to limit possible exploitation, and for us it's to promote a trauma-informed environment. And we're going to talk more about the core values of trauma-informed care, which I printed out and are on your table because we're going to use them in a little discussion later. But the core values of trauma-informed care, and this is in the trauma-informed care training, but I wanted to mention these because I think sometimes we lose track of what trauma-informed care is because it's sort of a part of our fabric. But really what we want to be promoting in our environments is safety, empowerment, collaboration, trust, and choice. That those are really important things for us to make sure that our clients have. So if we fail to maintain strong boundaries, or those strong professional boundaries, some of the potential results of that could be violations of confidentiality or privacy, or we might allow some of those client rights to be violated if that becomes more of a personal relationship than a professional relationship. Because those confidentiality and privacy laws don't apply to our personal relationships. You're not under HIPAA when you talk to your best friend and they tell you something personal or private. So if you start to think about your relationship with a client in those terms, you might lose sight of these things that are really important for us as professionals to uphold with them. It may lead to discrimination or favoritism, sort of treating clients unfairly, and again, that's the point of boundaries, is to make sure that we're treating our clients fairly, and then we're not either giving them favors because we like them a lot or discriminating against them because we don't like them a lot. That's a personal dynamic in personal relationships, not a dynamic that we want to have in our professional relationships with clients. Again, it can lead to maltreatment or coercive behavior and or emotional or financial abuse. We want to make sure that we're conscious of the power that we have and not misusing it. And again, because we're a licensed facility and most of our professional staff are licensed by a board, there are a lot of sanctions that can happen if there's boundary violations or ethical violations. What are some other risks that people think of in terms of not maintaining good boundaries with clients? Throw them out. Other potential things that can happen if we don't maintain strong boundaries with our clients.
Could foster dependency.
Foster dependency, that's a great one, yep. We could encourage them to rely on us for everything instead of them being empowered to make their own decisions, and yeah. Anything else people think about as a risk or a time when boundaries come up as something that we talk about. Marcia?
That they feel that they can continue to keep calling after the discharge for an indefinite period of time.
Say more about that. Are you taking a risk of that or a benefit of that? Or time that comes up?
Well, I'm talking that it might, well, it's actually what was said at the first table about the line review. You know, if they go somewhere else, if they're sober housing or they have someone else, they should be switching that alliance to that person.
Sure.
So we could prevent them from getting close to someone else.
Sure. So yeah, again, it kind of all the preschoolers going to lunch. Going along with what Jake said about fostering dependency, that our clients do eventually move on from Wayside, and we want to encourage them to keep connected with us, and that's an area in which we have to be aware of our personal and professional boundaries, or in some ways that may be fostering dependence on us, in some ways, so kind of creating a healthy boundary for former clients is a good maybe way to summarize that we do want them to stay connected, and that's still a professional relationship, unless it becomes a personal relationship, they become a coworker, or things like that happen. Kelly?
One of the things I think a lot about in terms of boundaries and residential treatment is kind of recognizing that what I say to one client will be said to every client, and knowing that and being intentional about it, because that's just the nature of it, and it gets passed on like generation to generation throughout the house. So something I said about myself 2 years ago will still be known by my clients right now, even if I've never said it to them.
I don't know how to summarize that. Being conscious of what we say to our clients, because we can't necessarily control what is done with that information once it is in the client community. And like we've said before, clients, I don't know if we've all said this before, but in some meetings I've been in before, we talked about that the clients aren't bound to HIPAA or privacy or confidentiality laws like we are. We of course want them to uphold confidentiality of other clients and privacy of other clients, and there's no legal ramifications if they break that, whereas we have legal ramifications if we break that, so being really conscious of that. Let me go to Erin and then back to Karina. Erin.
I think, along with Kelly, it's like it can create division and cliques in the community and division in the community, and if like we don't maintain boundaries and treat everyone equally, then it's noticed by the clients that these are like, I think more like cooler, fun, or like, I don't know.
Oh yeah, well yeah, if there's any discrimination or favoritism, the clients know. The clients are aware, it spreads like right, they're very sensitive to that fact about who's being treated fairly, unfairly, better than someone else, worse than someone else. So yeah, we have to be really conscious too about their perception of our boundaries too. Karina, do you want to say something?
Yeah, just that when we allow the boundaries to get fuzzy, it impacts our ability to provide clinically sound care. So we no longer lose, we don't have the same ability that we had before that attachment occurred.
Yeah, so yeah, we're going to talk a little bit more about that too, about we lose our objectivity a little bit, and that's another feature of a professional relationship that we really want to maintain. That, oh goodness. Oh, okay, so why is it important to pay attention to boundaries? All the reasons we just talked about. It reduces the risk of client exploitation. That sort of legal issue is foremost on Wayside's mind, that we want to be really protective of our clients. I think it also reduces client anxiety if the rules are really clear to them and they don't feel like certain people are, the rules apply to certain people and not to others. So it's a way of letting them know that things are consistent and that they're going to be treated fairly and equally, and that that's an important part of their treatment with us. It increases the well-being of the staff, to be honest, as well, because you're not sort of having those same feelings or emotional reactions that you might be having in personal relationships, as this is a professional relationship and we know the boundaries, and that helps us to know sort of our limits and our work, where our work starts and ends. And it provides role modeling of healthy relationships for clients, that they have to be setting boundaries themselves, and the way that they learn that is to see other people doing it. Who is in charge of maintaining boundaries? We are in charge of maintaining boundaries, not the client. It's the duty of the worker, and we're ultimately responsible for managing boundary issues. We can't expect our clients to do that because we're the professional. Clients may not be aware of the need for boundaries or be able to defend themselves against boundary violations. And because of that inherent power imbalance between worker and client, the worker is perceived as having more power and control, and we have a code of ethics to uphold, they don't. So some common boundary issues that may come up, or things to be aware of as boundary issues: working within our competence or our scope of practice, making sure that we're not assisting someone outside of our area or outside of our expertise or outside of our job role here at Wayside. So if you're feeling really connected to a client, not offering her advice if you're not her counselor, or sort of, talking about her medical needs if you're not the nurse, but making sure that you're working within your scope of practice. Giving and receiving gifts comes up at times, and again, this is about something that's of significant value, that we don't want to be giving or receiving gifts of value, because that, again, is leaning more toward a personal relationship in which there's not a power imbalance versus one where there is. And I always think of the worst case scenario is that client reframes that as that we took something from them, or we gave them something personal, and we have this personal relationship now. So thinking about the interpretation of it on the other side. Dual relationships or conflicts of interest. We'll talk a little bit more about those in the past. That's having sort of more than one role with a client. Becoming friends or socializing with clients. Again, that's a personal relationship. This is a professional relationship. Encouraging dependence, we talked about that. These are boundary issues that come up. And then again, physical contact and sexual relationships. There are a lot of laws, and your code of ethics, I printed out as on your table. There are laws and rules about sexual relationships, certainly with clients. Physical contact is a little bit of a gray area, and again, we want to make sure that we're maintaining a professional boundary with that, not a personal one. Finn?
Yeah, something about this that I think is interesting is the 2015 stats came out for BBHT, and in the year of 2015, they had 16 concerns with sexual contact with professionals, and as of this year, we've already reached 16.
Wow.
So, and we're only in
April.
So I think that's really important for us as professionals to know. So there's something different about reporting, which is good. People are reporting their colleagues more.
Yep.
Or there's becoming sort of a lax environment around ethics. And so I just think that's really, BBHT is all of our licensures for substance abuse. And so I just think that's really important to know about that change. It's a huge change, statistically.
Yeah. Wow.
That's statewide. Right, that's statewide.
And that's public information. You can look on the BBHT for anyone who's licensed through them, and there's any violations in their history, and really a lot of details, more than you would think, about why those violations happen. So, and that's, we can do that, clients can do that, anybody can. So just areas, I don't wanna call these danger zones. It was, this predates me, this slideshow predates me, but I've updated it. So, but I would say areas in which you wanna make sure that you're thinking about boundaries. If you are feeling like you over-identify with a client, or you feel something really in common with them, you're sort of taking on or personalizing some of the things that they're talking about, or you can really identify with what they're talking about, that's a time to think about, I have to exercise my professional boundaries in this relationship. If there's a physical or emotional attraction to a client, certainly that's a time to think about and seek supervision about boundaries and how to enforce boundaries. If there's any potential for gaining rewards from a client or from a client's influence, that's again a time we want to be sure that we're talking about boundaries and thinking about boundaries so that we're not exploiting or misusing our power in that situation. Transference, which is from the client maybe putting emotions related to someone else on you, or countertransference, maybe we putting unresolved issues on the client, or sort of assigning something that's not about them particularly, but is something personal about us. Those are issues where when you feel like and these countertransference and transference are normal and happen all the time, and it's a time when you want to think about boundaries and think about how you maintain a boundary with somebody who reminds you so much of your sister that you wish would just go get help, or is bringing up something personal for you that you know that you need to work on, that you know that that's yours, that's not the client's, and we make sure that we're maintaining that boundary. And then self-disclosure, a little bit of more discussion about self-disclosure, which means how much are we talking about ourselves to the clients. And sometimes they ask a lot about ourselves, and so how much you disclose is really a judgment call. But any self-disclosure really should always be in the best interest of the client and for their benefit, not for yours, not because you want to talk about something that just happened to you, but what's the benefit for the client? This is about their care, their in care. Making sure the self-disclosure is relevant to the client, disclosed for a specific purpose, not just because you're chit-chatting and you wanted to tell them about your significant other. And thinking about, using some judgment about when, what, and how much you share with the client, and for what purpose. Just thinking about that is a good guideline. And self-disclosure is done to facilitate a relationship building. That's okay to share with a client in terms of relationship building if you're building that professional relationship. You're not building a personal relationship with that client. So talking about, here's why you should trust me as a professional in your life, or here's what kind of relationship we have as a professional. You might do some self-disclosure to enhance that. That's okay, as long as you're keeping that in mind that it's professional. I think you guys know what happens if we disclose too much or too often, so we're not gonna generate answers there. So questions to ask yourself if you're thinking about potential boundary issues. Is this in the client's best interest? Whose needs are being served here, mine or the client's? Does this client need something special to me, or do they bring up something really personal or hard for me? Is this client hard for me? Am I taking advantage of the client in any way? Am I being sensitive to potential trauma? Because a lot of our clients have trauma around attachment and boundaries, and that may be really hard for them to maintain boundaries because of trauma that they've had. So making sure that you're not triggering something for them or playing into something for them that's sort of repeating trauma that they've had. How would I feel telling a colleague or my supervisor about this? That's a big one. If you have hesitation about talking about this with coworkers or supervisors, that means you need to. You need to seek supervision, and that means that there's probably some boundary issues going on there. Oh, wait, the last one's really important. How would I feel charting about this? I think that's, in my mind, think about that too. Like, what would this look like in a chart note? That's gonna help you realize, did I say the right thing? Did I say too much? Because if it's not documented, then that's unethical in some ways too, and it's probably a clue that you crossed a line in some way, or that relationship was not just professional. Questions about those? Or any of this? You know, got fans on? Okay. Dual relationships. This comes up quite a bit in our community. If we have more than one role with a client, so things like we know them from the past, or we worked with them in the past as a professional, and now that we have a personal relationship with them, things like that can come up and can blur the boundaries. So a dual relationship in and of itself is not negative. That may happen, and as long as we're conscious of how we maintain boundaries in that dual relationship, it's possible to. We've had clients before who attended meetings with staff before they came into residential treatment, so we knew them. We have a dual relationship because they used to be a peer and now they're a client. So there's nothing wrong with having that dual relationship. It's how we handle that and maintain boundaries in our new role as a worker with this client, to make sure that we're not exploiting them or pretending to still be a peer when we're actually not. Again, it's our responsibility to be aware of that when we have a dual relationship and to manage and make sure that there's no harm that comes from a dual relationship. These are some examples that are unavoidable. If you belong to the same church, your client works at a local business, and you frequent that business. If your agency hires clients as staff or utilizes clients as volunteers, which ours does, so those past clients then become coworkers, and there is a different kind of relationship. So making sure those relationships don't become exploitative is really all about maintaining boundary and talking about. So being open and honest with the client about the nature of the different relationships and of the relationship that you're in as a person specifically. Having sort of, being able to talk about with clients that there's separate functions, that your function at work and your relationship with them at work might be different than a relationship outside of here, and that you're still upholding your ethical boundaries. Being aware of threats to confidentiality when you go out into public with a client and you're talking with them about treatment, or if you're meeting them for coffee or something like that is happening, making sure that you're still maintaining those ethical boundaries and maintaining those client rights. Understanding your role and the rules that we have to follow as professionals, and again, seeking supervision. That's the most important part. If there's any question in your mind about boundaries and how to uphold them, seeking supervision. So a dual relationship is having more than one role or relationship with a client. A conflict of interest is having a dual relationship that then affects your motivation or decision making in working with that client. So it's when you have a dual relationship and that may affect their treatment. So we often talk about this. We've had clients that have a conflict of interest with another client that's in treatment. They know each other. They may not be able to work together in the treatment facility or get their best treatment. But this can also happen with clients and staff, as far as if there's some sort of conflict of interest, that means that they're not going to get fair treatment or ethical treatment in our facility because our motivation or decision making and working with them is impaired. So we're gonna be alert to potential or actual conflicts of interest. Be aware that isolation is often a major factor for staff or professionals in ethical violations. I think that is something to what Finn was talking about with the enhanced reporting of ethical violations, that maybe there's some isolation factors or personal needs that are not being met in other areas of professionals' lives. So again, it's meaning that you're not bringing your personal needs into this relationship with a client. You're finding ways to deal with your personal needs outside of work or outside of that setting, and keeping your work relationship focused on the client and their needs.